Thanks,
Dr. Ali.
Dr. Muthanna. I'm Dr. Adnan Taan from Iraq, intervention cardiology at Nasser City Hospital at Egypt, and at Arabi Hospital at Iraq. Today I'm gonna present STEMI with no culprit. So our patient was 30 years old, male, heavy smoker, history of sudden severe chest pain for 2 hours duration. A presentation, the patient present with ST elevation in the inferior lead, lead 2, 3, and IVF, and reciprocal in the lead 1 and IVL. This is the ECG. You can see the elevation in the inferior lead, and I just skipped the echo. It was nearly normal. So we just shift the patient for the cath lab. After we shift it, directly we cannulate the left system, and you can see the views of the left system. For the first view, it was clearly normal. Second, it's also normal. So this is the left system. Let's get little back for all the left again. And now the RCA. Sorry. Before we shifting, sorry. Okay. So here the left and the right system both together. At that moment, the next thing, what do you say? What's next? We are going to do this patient, 30 years old, present to us with STEMI, patient ongoing chest pain, and you can see the left and right, it's clear. Unfortunately, there's extra footage for the right system, but it's not here. So we go back for the control room. We discuss, me and Professor Adnan Taan, he's the head of the cardiology department in Arabi Hospital, and we recheck the views before, is it vasospastic angina or it's a thrombolysis, spontaneous thrombolysis. So which is the plan for us for that patient? Just we put him for therapy or we send him for CT scan. But we, after reviewing all the footage, we check something here. If I can, no. Yeah. If you can see the stamp over there. So we decide to proceed. We cross by software BMW, after by balloon, just like minimal BTCA over there. We decide to stent, and this is after stenting. Sorry, and here after stenting. Post dilatation, and here is the final result. So we can see now how it's look like. It's actually, it's not a branch of RV, no, it's split RCA, or we can call it double RCA. It's a huge, it was missing. We thought about it also because, you know, an anatomical area, it wasn't coverage at all, and you can see the beginning, the ostial of the RCA, it was huge. It should be cover more area. So it's increase our suspicion for looking for another thing. So this is the ECG of the patient. After we finished, he become normal again. He came back to his lifestyle. He's young, he's 30 years old. He came back to sport, and he's living normal nowadays. So the take-home message, split RCA is the same anomaly as the embryo named double RCA. Split RCA is the most common anomaly with the frequency of 1.2. and is considered to be benign, not associated with any symptoms, don't warrant specific treatment except for the presence of atherosclerosis. Two separate arteries arise from the aortic trunk, or RCA bifurcate into two major arteries, anterior and posterior division, immediately or few millimeters after its origin from the right sinus of Valsalva. It's important for the intervention cardiologist to keep in mind this anomaly in order to avoid wrong diagnosis considered as RV branch and inadequately treated. So thank you for everything. Thank you.